Good morning, everybody. It is 7 o'clock my time. Jenna's time, we're looking around 10 now, but both of us were just talking about waking up in the morning. So, what better way to wake up, Jenna, than hearing a screaming child? And that's what ended up happening to me when I was a kid, Jenna, so everybody, the Perfecting Peds show today is about something that, is honestly near and dear to me because as a kid, having earaches was the worst. I remember laying on my side, hand up against the head, trying all the different tricks and just nothing working. It just happening kind of over and over and over again. We'll get to another subject here soon, so stay tuned when we talk about tubes. But just in general, Jenna, you and I wanted to talk today a little bit about what is treatment for otitis. How do we recognize it? How do we move forward down the algorithm? And as healthcare providers, pharmacists, what do we do? What's our role? Jen,
Yeah,
I'll pass it over to you.
yeah, thank you so much. It's always a pleasure to chat with you. Today we're going to do a quick review of the otitis media guidelines. I was reading last night, honestly, to try to see so the original one came out in 2004 and then it was updated 2013, and we don't have anything since then. So I was just, double checking because sometimes you're like, you don't even know that there was like a recent publication, but I couldn't find much, except like some people just trying to push the use of them more to really highlight, which we'll talk about, which is like the wait and watch, which is, depending on the child's presentation, you may have some parents showing up at your pharmacy saying, hey, the provider said, not to fill this for 48 hours unless my child gets more ill or has more ear pain. And so I'm going to give this to you. Can you put it on hold? And I may need it in, 48 hours. So we'll walk through the recent guideline. Well, not recent, but the old guidelines. And then they did some newer publications just to emphasize the wait and watch, which we'll discuss.
Let's do
So
it.
really depends on, for the first thing that you'll see is it really depends on age. So we're a little bit quicker to treat kids that are in that 6 months to 23 months age group because, one, they're younger and they can get quicker or more quickly get ill and decompensate. They would always say in residency and my pediatricians throughout my training, I would always hear them say, babies look good till they're dead. And that's always stuck with me, which sounds crazy, but it's like, the younger they are, the easier and faster they can get acutely ill. So that's always stuck with me. So the clinicians should prescribe antibiotics if it's in that age group of 6 months to 24 months of age. If the child has, if the child has any mild, they're going to talk about really the pain scores. So any even mild ear pain for less than 48 hours, or even a temperature less than 102.2. So it's going to be different when we go up in age group. But if they have that bilateral otitis media, so you're going to hear, is it in both ears or one ear? So if they have bilateral otitis media and they're in that 6 months to 24 months age group, then you, even without severe symptoms, so even if they have mild ear pain and not even a really necessarily high temperature, they do want to get them antibiotics. Anybody that, regardless of their age, if they have the bilateral or unilateral, but they have severe symptoms, which is really bad ear pain, or a temperature greater than 102.2, you prescribe antibiotics. And that's always where my middle child was. She would get like 103, 104 fevers, and she would get really sick. So every time we went, she actually ended up septic in the hospital from an ear infection that I was literally at urgent care the night before, and she was not responding to anything, so she had to get IV antibiotics, which is a rare case, but just to she'll be the highlight of our show as we go because she's now my tube child. And then so clinicians can either prescribe the antibiotic or offer close monitoring. So what they do is called the wait and watch, and this is really with the parent or the caregiver's consent and involvement. So they make sure that the parent's okay with it. So if you have a unilateral otitis media in that young age group, so just one ear from the 6 to 23 without any severe ear pain or those high temperatures, you can do the wait and watch, which is basically saying, here, you have this script, but wait for 48 to 72 hours before you fill it. And the reason you would fill it is if your child has more ear pain or develops a worsening fever. We know that a lot of times that it will resolve without any antibiotics, and that's because sometimes it's viral. And it's really hard when you talk to pediatricians to differentiate. So they just really go based on this algorithm. Again, you can do the wait and watch for any child that's 24 months and older if they don't have those severe signs. So if they have mild ear pain, but it's less than 48 hours, or they don't have a high temperature, again, the provider can provide that script and say, hey, wait to fill it unless they have severe pain or pain, greater than 48 hours and that fever. So sometimes I'm assuming you'll have a parent come in and just say, hey, do you mind just putting this on hold? And we should encourage that, because obviously we want to minimize the use of antibiotics, which we'll talk about in our next show as well. But the last two highlights are really, as a pharmacist, what bugs do we think about? It's H. flu, Moraxella, and then your strep pneumo. Again, highlighting the importance of vaccines. And so with otitis media, our first line is amoxicillin, and that's assuming that they do not have they don't have purulent conjunctivitis or anything going on with their eyes. So first line's amoxicillin. The second line is Augmentin, and the reason you would use that is if you have that conjunctivitis in your eyes, or if the patient has failed or been on amoxicillin within that 30-day period, and you're deeming that they failed it, and so you would up the therapy and do Augmentin. So this just happened to my 9-month-old, because she's going to get tubes too. I just know it. The best way to prevent ear infections, if you can, is breastfeed. But irregardless of me breastfeeding, my kids just have really bad ears. But so it's like, can't win. So she had a month ago, she was on amoxicillin. She had severe ear pain, and she only got up to 101, but because of her ear pain, she got herself antibiotics. She was on amoxicillin, and then 3 weeks later, she presented again with bilateral ear infection, so they did Augmentin. I hate Augmentin. Just be really cognizant of the strength that you're going to give your patients, because if you're doing high dose, you need that 600 per 5. There's various different strengths of, as you know, Augmentin and the clavulanic component. And the clavulanic is what's responsible for all that nasty GI effects that we see. So even with my own daughter, giving her probiotic each day, I love like Culturelle Kids, she's still having that nasty diarrhea, which then evolved into that awful diaper rash. So I just was like letting her hang out all day without a diaper and lots of zinc oxide. But that's just a quick review of the guidelines, what to expect as a pharmacist. And then next week, we'll talk about really, you'll hear me stress trying to minimize the use of antibiotics. I know it can't be done. Like in both my girls, they would get so sick. But if it's, if there is the ability to do the wait and watch and the symptoms aren't that bad, as pharmacists, we should really encourage that. And then we'll talk about, various more escalation of antibiotic therapy if needed, but then also ways we can try to help our patients avoid antibiotics if possible in the upcoming shows.
Awesome. I love it. Yeah, I think that just going over those, Jena, and looking at unilateral versus bilateral ear infection is an interesting thing, because there's so many just pieces of general anatomy, that we think like, why did my poor kid get hit with the double versus the single, or how bad is the infection one way versus the other? The only thing I know we're, right at time to be able to sign everybody off is everybody just wanted to let you guys know if you want to find out more about what Jenna's talking about, get more guideline basics and some things that she has already in store for you and packaged. Check out everything that she has on her Perfecting Peds page at RPH Ally and join the crew over there. And then Jenna, for next week, just to leave a teaser for the crew, what we're covering is not only going over kind of the antibiotics that are there, but I'll ask Jenna a little bit more about some symptom control. What she's used previously, some over the counter, some behind the counter, some home remedies, because I think that one is another piece. If we're watching and waiting, a lot of parents are very anxious. So giving them something else to do is a big piece of that puzzle. But thank you so much, Jenna. You're wonderful on these with all this great information, and we'll talk to you again soon.
Thank you, Kev, for having me.
All right. Talk to you guys then. Bye-bye.